All right. Well, welcome everyone. Thanks for spending time with us today. I'm Tony Lowe with the VFW Foundation, alongside Dan Wisnett from SDV Medical, and we're here to talk about something that hits home for a lot of our community: toxic exposure and respiratory health, and how the PACT Act is actually changing the landscape for veterans. Now, this isn't a sales pitch. It's not legal advice, but what it is, it's a veteran first discussion that's going to help you understand what the law is, why it was needed, and how to take action if you or someone you love have symptoms or concerns. Put your questions in the comments. We will not respond to them live. We will take those back, and Dan and I will answer those questions and make sure you get resolution to your questions or concerns. But first, let's start by introducing everyone. I'm going to turn it over to my teammates here, starting with Dan. Introduce yourself. And
thanks, Tony. Dan Wisnett. I'm the co-founder and president and CEO of SDV Medical. We are a contract holder. We hold a sole source contract for all Intuitive products. We'll be talking a little bit about that. But we are a service-disabled veteran-owned small business located in Asheville, North Carolina, roughly 30 employees. And our sole focus, obviously, is to help our fellow brother and sister veterans on their journey towards healing. And part of that is the technology and the docs that you see here on the screen, making sure that veterans like myself, I'm a VA patient myself, and we get the care that we deserve and the technology access that we deserve. So appreciate it, Tony.
Thank you. Dr. O?
Hi, everyone. My name is Scott O. I'm a practicing interventional pulmonologist. I've worked at the West Los Angeles VA from my training days to now. It's been, I think, probably around 20 years or so. I've been working at a VA medical center, do a lot of bronchoscopy and take care of patients with lung disease. I'll pass it along to Dr. Flora.
Hi, my name is Arjun Flora. I'm an interventional pulmonologist at the New Mexico VA Medical Center. I previously worked at the Memphis VA in Tennessee, as well as the Cincinnati VA in Ohio. And just a little fun fact, I'll be swearing in to the Army Reserves as a major with the Army Medical Department in the next couple of weeks.
Wow.
That's outstanding.
Congrats.
Congratulations.
Yes, congratulations and thanks.
Excellent. Well, thank you, gentlemen, for taking a few minutes there. Let's jump right into it. Let's talk about what the PACT Act is and why it's so important. And we kind of set the scene with that, and we'll drive into talking about technology, equipment, and some of the things that our veterans and members out in the community, what they can expect to see at VA facilities when they start to inquire about their lung health. So, what's the PACT Act? You know, the PACT Act was a landmark law that expanded VA healthcare and disability benefits for veterans exposed to burn pits, Agent Orange, radiation, and other toxic hazards. The big shift adds presumptive conditions. There's like 20 plus presumptive conditions and exposure locations added to this list. Bottom line, it helps veterans get care quicker and faster, access to their benefits. We were instrumental in pushing this PACT Act across the finish line and getting it implemented. There's lots of information out there available on va.gov, pactactinfo.org, just a couple of places where you can find additional information on the PACT Act. So why was it needed? You know, for too many years, we had veterans returning from conflicts, and it was a uphill battle. It was a struggle to get their illnesses connected or service connected after they were exposed to toxic environments, burn pits, airborne hazards, and the like. The PACT Act reduced that burden. So essentially, as I mentioned, it loaded or preloaded some presumptive conditions and locations to eliminate or decrease the paperwork that was really cumbersome for our veterans. This is a multi-generational type of issue. So we've got the Vietnam era veteran, we've got Gulf War veterans, we've got post 9/11 veterans, all using the same resources and accessing the benefit. So let's start talking about some of the equipment or gaps in service delivery, gaps in capability, some of the VA equipment that's out there. Dr. Flora, you've conducted a national survey recently about VA pulmonary programs. Can you speak to a little bit about that?
Yes. So earlier this year, we had done a group of interventional pulmonologists throughout the VA system. We had conducted a survey of lung precision oncology program. So the VA LPOP is basically concerned with both lung cancer screening as well as advancing cancer treatments, especially along the lines of molecular analysis and many of the newer drugs, such as the different immunotherapies and targeted therapies. We reached out to 96 of those programs. Only 76 responded. It was a very busy survey, but we were really trying to get at the nitty-gritty of where are the barriers and limitations, as well as accessibility of advanced pulmonary therapeutic as well as diagnostic equipment. So of those programs, 94% of them have lung cancer screening programs, but only 30% had an interventional pulmonary program. And then in terms of incidental nodules, so these are patients that just randomly are found with a nodule, only about 50.8% of them actually have an incidental nodule program. But when you're breaking down in terms of the equipment, in terms of being able to not only diagnose but stage at the same time, 56.7% of the programs had something called endobronchial ultrasound. So that's a bronchoscopic approach with an ultrasound in order to biopsy lymph nodes and other particular lesions away from kind of the primary kind of spot or mass. So 56.7% had both robotic bronchoscopy for an advanced, high diagnostic yield for biopsying a nodule that's kind of farther out. 26.9% had EBUS with one of the older forms of whether or not they had some sort of navigational system versus even just going old school with a small scope and fluoroscopy or movie X-ray. And then 16.4% had no program whatsoever, had no equipment. And so that was quite telling. And then of the breakdown of those programs that did have robotic bronchoscopy, 89% of them had the intuitive ion, and then about 5.6% had both an ion and a different system called a monarch, and then 2 programs had a monarch.
Dr. Flora, I apologize. What was that first number that had the ion?
If you were to combine both those who had both systems as well as just an ion by itself, would be 95%.
Understood. Thank you. Thank you for sharing that. Dr. O, you've heard some data there, especially with the technology, the equipment piece of it. Can you speak a little bit about the intuitive approach and the equipment that's utilized?
Yeah, I think probably the bigger picture is generally speaking, bronchoscopy versus CT guided biopsy are the 2 most common ways that minimally invasive biopsies are performed in the lungs, particularly when it comes to what we call lung nodules or spots in the lung that are oftentimes, we're concerned about cancer, that these nodules may be cancer. Some of them warrant undergoing a biopsy to help sort out what they might be. And the latest technologies for bronchoscopic approaches involve robotics. So robotic bronchoscopy in general, I think, is probably the type and the way that we now most commonly biopsy lung nodules. And then the other common way is CT guided biopsy. In general, the latest data suggests that robotic bronchoscopy performs just as well as CT guided biopsy in figuring out what these nodules are, but in a safer way with less complications. And then the latest, super latest data, which is just a few days old as far as being published, although it wasn't a head-to-head comparison, suggests that robotic bronchoscopy may even be better than CT-guided biopsy in figuring out what these nodules now are, with the latest combination of technologies, which is combining robotic bronchoscopy with something called cone beam CT, which allows us to get a CT scan during the time of the biopsy, which gives us another level of accuracy in trying to figure out what these nodules are.
Thank you. That's amazing, Dan. I think I read that veterans are 4 times higher at risk for lung issues, lung health issues, pulmonary respiratory issues. How can you speak to early detection, intervention?
Yeah, I mean, I think everyone knows a lot of veterans smoke. Compared to the population, there's an overwhelming majority that are smokers, and I think Dr. Flora and Dr. O can speak to the fact that probably the first step is stop smoking. That's probably the best thing you could do for yourself. But then military members like myself who were deployed multiple times to Iraq, Afghanistan, other places have been exposed to things that we just don't know what we were exposed to. So the key thing is, if you're a veteran and you have access to the VAs, go get screened. That's the very first step. So if you're a smoker, stop smoking, and then 2, get yourself up one day, get in the car, and go to your local VA and get a screen. It's completely free. You're going to know, and then you're going to be in the good hands of docs like Dr. Flora and Dr. O, who can then manage your pathway if they do find something. That's the great thing is, I think, these 2 gentlemen would attest, as well as their peers would attest, is the watchful waiting piece that has been going on for years now. It's been the standard, if you will, for lung cancer. That can be a thing of the past. It should be a thing of the past based upon the technology that's available to everyone. And the access now with the PACT Act allows you to go in, get screened, and then get that diagnosis right away if they do find something in those preliminary stages of the imaging process. So that's what I encourage all veterans that I run across to. I say, go get screened. Yeah,
I love it. Early intervention is key. I think we witnessed a little of that at the VFW National Convention, where Intuitive had the equipment there on site, and it's about awareness. We as veterans in the community, we're just not aware that this emerging technology is sitting right there in their VA medical centers that they more than likely frequent. And to your point, the PACT Act, the screening, it's harmless. It's non-invasive. It's easy. So yes, I would foot stomp that, and please encourage everyone that's listening, watching this, every veteran to please seek out the PACT Act screening. Again, go to va.gov, go to your local VA medical center, and request that.
I can actually speak to some extra numbers, at least locally here in New Mexico. I've only been here for 18 months. When I first started my program here, building up this interventional program, we were kind of fledgling a little bit, had nobody for the last 5 to 6 years doing anything for lung cancer. About 87% of my cancer diagnoses when I first started were late stage, stage 3, stage 4. Since we've built up our lung cancer screening program, which is the only center of excellence for lung cancer screening in the state of New Mexico, not even any of the private hospitals or the academic hospitals are, just us at the VA, as well as getting our robotic bronchoscopy program going, that number dropped down to 16%.
That's incredible.
Yeah, I'd like to echo all the sentiments that were expressed and how important it is. The 5 year survival, if you detect lung cancer early, it's highly curable. Um, the earliest stage lung cancer, stage 1A1, has more than a 90% 5 year survival rate, right? So if you catch it early, you're going to get cured. Chances are. But if you get diagnosed late, then it becomes a largely incurable disease. So being able to detect it early, diagnose it early is absolutely essential in improving the outcome. So I would imagine that 5 years from now, with the higher percentage of earlier diagnoses that Dr. Flora is making at his VA center, that the survival for lung cancer at his center is going to improve because you catch it early, you cure it early, then the lung cancer outcomes are gonna be better, without a doubt. The other thing I wanted to important is lung cancer screening is absolutely important. Assuming that you qualify, and it's like anything, right? A 22-year-old veteran who's never smoked their whole life probably doesn't need to get screened. So there's the right patient to go get screened. So if you qualify for it, absolutely, you need to go in and get that done, 100%. The other thing that's really important is we do CT scans for all sorts of reasons. We can do a CT of the chest, not for screening, for other reasons, and incidentally find a nodule. You can do a CT of your head and neck that gets the upper parts of the lungs. You can get a CT of the spine that images the lungs around the spine. Your CTs of the abdomen and pelvis, or of your abdomen, get the lower parts of the lung. When you get a CT coronary angiogram to look for, your heart vessels, you scan the majority of your lungs. So the lungs get scanned in so many different ways that we detect a lot of incidental nodules. And if you get a CT scan, I would encourage you, get the report, read the report yourself. And if it says a lung nodule is there, ask your doctor about it. Say, what is this thing? What is this nodule? Do I need to do anything about it? Because those are there. We know they're there already, but they kind of get lost in the shuffle a lot of the times because that's not the main reason you had the scan done. You didn't get the CT of your head and neck to look at the upper parts of the lung. So they just kind of get neglected and put by the wayside. But there might be something there that's worth figuring out what it is. So those incidental nodules that get detected, there's a lot of them. There's a lot of them out there. So those are important to sort out as well.
Those are excellent points, Dr. Rowe. Thank you for sharing that. Dr. Flora, let's talk. Let's start with you by talking about specific exposures and gaps in research. I know we've had there's a new research, or let me back up. Let's talk about some some research or ongoing research. Um, exact toxic exposures and which specific agents correlate with particular cancers. Can you deep dive a little into that?
Sure. So a lot of it is actually unknown because the quality of research specifically delving into respiratory, so upper airway or even lower airway for the lungs, is not really strong at this point. So even before the PACT Act, for example, when the National Association of Science and Medicine was looking into this data, when VA home, which is the health outcomes, military exposures, up until the PACT Act, it was only biologically plausible as opposed to a presumptive condition. And because of that research, which was good research, but very limited at that time, because there's a latency period as well. You're not going to just get exposed to a military occupational exposure and all of a sudden you develop cancer. Now we're several years out, actually decades out from the start of the wars in Afghanistan and Iraq, but then even just from the ending of the wars, we're so far out. So I'm actually working with several other interested physicians and researchers within the VA system, such as Drew Moganaki that works with Scott O. He's the director of radiation oncology at the Greater Los Angeles VA. We are actually trying to delve into DoD data now to actually find out uh, basically where did individuals deploy, what were their specific exposures, And then kind of bringing up the airborne hazards and burn pit registry. That's also something very important that veterans need to register for, because that's going to help us figure out what those toxic exposures are. You could have been exposed to JP8. You could have been exposed to kerosene lamps by itself. You could have been exposed to cart paint. There's so many different exposures, and we just haven't been able to pinpoint what they are. Right now, it's just biologically possible. So we're working on that to really figure out what those risks are. And then we hope that that can actually factor into VA specific lung cancer screening, because right now we're just using kind of our general United States Preventative Task Force recommendations on who to choose for lung cancer screening, but we want to be very veteran specific in the future.
Understood. Yeah, thank you for that clarification. Dr. O, you have any comments or thoughts on that?
Yeah, I mean, the challenge is, when I've realized, I think you're an expert in something when you realize there's more you don't know about something. That's when you realize I kind of understand what's going on here, when I realize how much we really don't know about things. And I think that goes with the exposures, right? In modern day, with the amount of exposures that we get living in larger cities, with the type of pollution, with the type of exposures that you have in the military, and depending on where you were deployed, and the cumulative and synergistic in a bad way effects of various exposures, I think we're just really beginning to scratch the surface on how those things may contribute to overall lung disease. Pollution in large cities is a major issue, and their association with lung health. So I think it's definitely there's clearly a link, but what that link is and to exactly which substances, like Dr. Flores says, we know there's something there, but we just don't know the details really, and that'll take a lot of time and work to sort out.
Understood. So, Dr. O, you have since you have the floor right now, I'd like to offer you the opportunity to give us some closing thoughts. We'll go kind of a round robin. I want to wrap it up with Dan, who has an incredible story to share, but it kind of pulls everything together. But Dr. O,
Yep.
since you have the mic, if you could just give us some closing comments and thoughts.
I think to me, the big kind of issue is that lung cancer remains the number one cause of cancer death. Whether you're a veteran or not, it's just the number one cause of cancer death. It is a fatal disease. And the main reason why, I think, is because it's detected so late. So, it's important to figure out the biology of tumors and figure out, what types of treatments and medications work. But the low-lying fruit is really find it early, detect it early, diagnose it early, treat it early. That is the key, I think. So go get screened, go get your incidental nodules sorted out. And if there's something there, talk to your doc about it, your doctor, and get it sorted out and diagnosed and treated and cured as soon as possible. I think that's would be my takeaway to people, is that early, fast diagnosis and treatment is going to be essential to improving lung health specifically for lung cancer.
Absolutely. Thank you, sir. Dr. Flora, over to you.
I actually just want to continue with that same information that Dr. O was bringing up in terms of really actively seeking care. Don't rely on the system, rely on yourself. If you have smoked the equivalent of 20 packs per day and you're still smoking, rather one pack per day for 20 years, you're still smoking or you quit within the last 15 years, age 50 to 80, ask your primary care. Go to your CBOC and ask to be enrolled. Same thing with the incidental nodules. And then one of the things that I find very specific with my patients is don't be afraid. This is something that if we catch early, we can treat you. Don't be afraid of what could be found. Be proactive in your care. The way that the technology is, especially with robotic assisted bronchoscopy, the risks are getting a lot less. we're trying to find out something that where the risks are much higher by not taking care of it early.
Absolutely. Early detection, early is definitely the way to go for our veterans that are watching, listening to this. And I speak, on behalf of 1.4 million members of VFW that are out there. I think, again, awareness that technology is available. Um, it is something that's survivable if caught early, and it's important. To Dr. Flores' point, you're taking responsibility for your health. Go and be seen. Go get screened. Don't wait. Continue to inquire. Continue to have these great conversations or sensitive conversations with your doctor, your medical providers. Use your benefits. If you need help accessing those benefits, please reach out. Dan, I'm going to turn it over to you to kind of close us out, because you have a remarkable story to share that's very personal. And yeah, please.
I appreciate that. I think what I first want to say, though, is thank you to Dr. O and Dr. Flora for spending time and sharing their knowledge and information, and most importantly, taking care of veterans, my brothers and sisters, along with your peers across the country. That's, the selfless service is greatly appreciated. I deployed in 0405 to Iraq, just south of Baghdad, with my battalion commander, Colonel Mark Smith. He could be a doctor, maybe not a clinical doctor, but he was smart enough to be a PhD guy. But Mark Smith was our battalion commander, great leader, just one of those, Marines Marine. That's how I would describe it. He's just a Marines Marine. And he deployed subsequently, I think, 4 more times between Iraq and Afghanistan after that 0405 deployment. In 13, obviously started seeing some symptoms, not knowing what it was. There were some screenings done on his lungs, and then they found out, I think 3 years later, he did have lung cancer. And then unfortunately, we lost him in 2019. I am confident that if the technology that we have available today, Mark Smith would probably be with us. That's the key, because it's the power of knowing. That's what we're talking about. The power of knowing if you have a nodule or not. The power of knowing what that stage is, if it is staged and it is actual cancer. Knowing is I think 95% of the piece. First of all, you got to show up, like we've all been saying. You just got to show up and get that screening. But then following the process, putting yourself in the hands of these professionals that can then give you that power of knowing that it is stage 1 or it is stage 4, and things need to be taken care of. There's treatments available. There's cures available to what these gentlemen say. So take everything that we've been saying here and go to your VA, go to your CBOC, talk to someone, talk to your primary care doc. If you're not going to the VA today, and go get screened, because the technology is there, and these docs are there to guide you on that pathway to make sure that you are cancer free. Given that opportunity, but you got to go early, and you got to take the matter in your own hands. And guys like Mark Smith, unfortunately, are not here right now, and I know we can prevent that in the future.
Dan, thank you so much. Gentlemen, I just want to say thank you so much for everything that you do for our veteran community. It's remarkable, and it's greatly appreciated. And I just appreciate you spending time with us today, taking time literally out of your busy schedule to attend this and pass this information on to the veterans and families that need it. And it's, again, greatly appreciated. Again, everyone, if you need additional information, please go to pactactinfo.org, go to va.gov. You'll see quite a few social media posts. We'll have this recording saved and available for you. Any questions, please continue to submit those, and we'll get answers to your questions. Thanks for tuning in. We appreciate you.